the kind invitation. My brief today is to talk to you a little bit, not everything, on systemic therapy for advanced disease, that is lung cancer. I'm not going to talk about the neoadjuvant trials. I'm not going to talk about the adjuvant trials, but going to concentrate on systemic therapy in advanced disease. I'm specifically concentrating on the typically non-traditional methods of treatment. That is what we call as so-called precision medicine or targeted treatments for lung cancer. So why is lung cancer so important for all of us? So the reason is very simple. If you see the global estimated number of new cases of cancer and deaths from cancer, and you take the top 10 killers of from cancer, amongst those, lung cancer has the highest incidence as well as the highest number of deaths from across the world. So this is the global estimated number of new cancer cases from lung cancer and as well as their deaths. So the blue bar indicates the number of new cases, and that is the number of deaths. So you can actually see that 1, 2, 3, 4, if you take them as that. So nearly out of the 100 who are diagnosed, a little over 75 of them die without seeing the next year. So the mortality is pretty high. And the mortality is pretty high if you compare it with, say, breast cancer. This is the incidence of breast cancer, which is almost the same as the incidence of lung cancer. But look at the mortality. The mortality in the given year is just a little over 25%, as opposed to here in lung cancer, where it is over 75%. So it is very similar to what happens in carcinoma of the stomach, cancer of the liver, where incidence and mortality almost are neck to each other. So as many patients of lung cancer as are diagnosed in a year, almost a similar number die from lung cancer. And why does that happen? Simply because of the function of the stage at which the cancer is diagnosed. So the 5-year survival dramatically drops to a little less than 2.5% in stage 4, just over 20% in stage 3. It's about 42% in stage 2 and about 80% in stage 1. So what we understand from that is that majority of the patients of lung cancer, if you look at the graph on the left side, bar diagram on the left side, actually are diagnosed in stage 3 and 4 disease. And that is the reason for its very high mortality. So we know that out of the so-called 100 lung cancers, about 15% of them are formed by small cell lung cancer, and the majority are found by non-small cell lung cancer, 85% of them. Once again, if you look at the dissect non-small cell lung cancer itself, you find that the vast majority are non-squamous, 78%, which we in common terminology call them adenocarcinomas, but need not necessarily be adenocarcinomas. A good number of them are about 18 to 20% of them are squamous carcinomas, and rest of them belong to other histologies. So the vast majority of the lung cancer burden is non-small cell lung cancer. And amongst the non-small cell lung cancer, unlike in the past, say about 2 decades back, where squamous histology used to be the overriding histology, we now have non-squamous histology as the predominant cause histology in lung cancer. So this is actually a summary chart, which I will bring up at the end of the presentation. But what is important to understand is that we have to move away from histology if we want to treat lung cancer today. So if you just concentrate on purely the histological classification, so it doesn't make any justice to the patient. So as I proceed through my presentation, I'll show you why this is more and more important and why it is important to use molecular tools for the diagnosis of lung cancer. So what do? You need to do a molecular profiling on all with non-squamous, non-squamous component, or if clinical features are suggesting that there could be a molecular driver. What clinical features will suggest a molecular driver? An Asian, a woman, a non-smoker. So all these three will suggest that this patient is very likely to have a molecular driver. So if the patient is a non-smoker, happens to be a woman and belongs to Asia, we know, I will show you that data very shortly, that there can be a molecular driver. So if a surgical specimen is available, of course, perform the molecular analysis on the specimen. The most preferred, as I said, is a small bunch or a panel if it is available. So that is the minimum panel, EGFR, ALK-ROS, and BRAF at a minimum. But if a panel is available, spare some tissue to facilitate participation in a clinical trial. Should that be? There are a dozen clinical trials at the moment in India. So it would make sense to have some tissue available to do it. Well, we know that the next generation sequencing is the preferred method of doing a diagnosis, but there are very much validated assays within the country and outside the country, and everybody now agrees that in lieu of an NGS, one can do a validated assay to arrive at a molecular diagnosis to have treatment for advanced treatment naive non-small cell lung cancer. So if you have sufficient tissue for molecular testing, perform the molecular analysis. You can use liquid biopsy. Liquid biopsy, if you compare tissue to liquid biopsy, we know that the circulating tumor-free DNA is about 82% right in selecting a treatment as opposed to a tissue, which is about 55 to 56% right. So yield from a circulating tumor DNA or liquid biopsy, as it is called, is extraordinarily high in matching the patient for an available histological diagnosis to a molecular diagnosis to a targeted treatment or a molecular driver driven treatment. So if you have a therapeutic target which is positive, treat with standard of care based therapy on the presence of the oncogenic driver. So the oncogenic driver actually drives the therapeutic modality. Well, if there is therapeutic target is negative, perform a molecular analysis on the tissue biopsy specimen. Preferable again is NGS, and treat with standard of care based on the presence or absence of the molecular driver. And keep some for the immunohistochemistry for PD-L1 or PD-1. Well, if you have enough tissue available, perform the molecular analysis on tissue biopsy specimen, and then perform PD-L1 as needed, and then choose whether the treatment is dependent on the presence or absence of the oncogenic driver. So there is no excuse today to say that we cannot do a liquid biopsy for non-small cell lung cancer, simply because the offer made by Foundation One from Roche Diagnostics, which is free for every patient, irrespective of what treatment is going to be given to the patient, whether it belongs to that pharmaceutical company or not. Roche in India has come forward to do a circulating tumor-free DNA analysis free of cost for every single deserving Indian patient. So tissue is no longer an issue, at least in non-small cell lung cancer. So we can now, how do we choose? What are the ways in which we can choose? The typical is what I have put down here. You have a squamous cell carcinoma. There's no point in trying to do. Of course, you can still do. So directly do a PD-L1 expression. That is the current recommendation. You have a non-squamous cell carcinoma. So then you can are never are light smokers and less than 50 years old, so younger patients, do, in addition to PD-L1, keep it in the reserve, but do a driver mutation analysis of EGFR ALK ROS1 and a BRAF mutation. I will come back to why we need to do the BRAF mutation a little later. So we know that we can choose treatment based on EGFR ALK and ROS if it is a non-squamous histology, and we will do a squamous cell histology. We will do a PD-L1 expression. We will reserve a PD-L1 expression for a later date in non-squamous histology. So you have a patient who is inoperable. I won't say incurable. No driver mutation. So if you do the PD-L1 status and it is more than 50% positive, so we have not found an EGFR ALK or ROS in that patient, and you only found we could only do PD-L1, and the PD-L1 is more than 50, you can choose the first, second line, third line, and fourth line treatments as I have depicted here: pembrolizumab to platinum doublet to docetaxel to erlotinib or afatinib. If you have a lower than 50% expression of PD-L1, then the preferred treatment would be a platinum doublet with a PD-L1 or PD-1 inhibitor. And as a second line, if you fail on that, you can go to docetaxel, and as a third line, you can go to erlotinib or afatinib. That means we move the platelet doublet to first line along with the PD-L1 and PD-1 inhibitor. So there's a marked difference in approach nowadays, that even in first line, the preferred treatment for a patient who has a high expression of PD-L1 is immunotherapy, and not, I repeat, not necessarily a platinum-based doublet. If you have a poorer expression of PD-L1, then you choose the immunotherapy with a platinum doublet as the first line treatment. So this is purely a spectrum of what were the drugs which were discovered. Don't worry about the left-hand side. We are starting somewhere here. So although erlotinib was discovered in, gefitinib was discovered in 2002 and erlotinib in 2004. From this trial, we actually learned that it is indeed, there is a vast difference in Asians versus Caucasians in the expression of EGFR mutation status. And that is how we actually learned that a majority of our patients have a driver mutation which can be targeted. Then, of course, we slowly started adding many drugs, one after the other, and it is a matter of serendipity to actually look up a drug or look up a trial which is going around the country or in the world, so that you can start using the drug. So the color coding is simply to show that all the reds are EGFR TKIs, all the yellows are that is ALK TKIs, that is crizotinib, alectinib, and ceritinib, or brigatinib and lorlatinib, and so on and so forth. So we can use HER2i directed TKIs, red directed TKIs, MET directed TKIs, MEK directed TKIs, VEGFR directed TKIs, FGFR directed TKIs, and PDGFR directed TKIs as well. Now, we know that there are very many regulatory approvals available. So I have just listed what happened after the discovery of EGFR mutations. So that is the first gefitinib was the approval. Then FDA restricted the use of gefitinib. EMA gefitinib approval first line therapy in EGFR mutated patients, and so on and so forth. So we got many other drugs as the FDA kept on adding. And I have listed only till 2018 for want of space, but you can actually go all the way to 2013 as well. Now, why do we need to know the driver mutation status and what is the driver mutation's role in our treatment? We know that the vast majority of mutations are EGFR mutations, which are targetable. Actually, the vast majority of mutations are KRAS mutations, which we have just started learning how to target. A small percentage, less than 10%, are ALK, MET, BRAF, and HER2 positive. Even smaller percentage are RET, ROS1 positive. And a good number, that is roughly about 30%, remain without a driver mutation at all. So 30% is reserved to KRAS, 30% to unknown. The rest of the 40%, you have some targetable mutation in non-squamous non-small cell lung cancer. So this is a chart which shows how the incidence of mutations vary between early stage lung cancer and metastatic non-small cell lung cancer. That means if you had a patient whom you treated earlier and then you have a metastatic disease, the same mutation need not always be present. So what actually you find is a slight different way the patterns are presented. For example, here I have listed other genes as nearly 30%, but that shrinks to 7.8%. So as the tumor progresses from a early stage non-small cell lung cancer to an advanced stage non-small cell lung cancer, the incidence of the mutations also keeps getting different. KRAS remains the same. EGFR jumps by or doubles up. So EGFR is 14.2% here. It is 30.3% here. So it is important to understand that the tumor has different mutation pattern when you see in an early stage versus a metastatic stage. So it looks like getting this actually favors the tumor to present at a later stage than at an earlier stage, or the patients would actually not die early on in their disease. Now, if you look at the rare mutations, as I said, if we can delete the EGFR and the exon 19 mutations, you get very many different types of mutations. For example, exon 20 mutations, some complex mutations, and as I said, frame shift mutations, other deletions and mutations, other point mutations, exon 19 insertions, and E709X, so on and so forth. So you get a wide variety of mutations amongst these so-called rare mutations, some of which we normally actually do it, some of which we don't do it because we don't have any targetable drug. So the argument is, what's the point in doing it since we don't have a drug to do it? But you may have some clinical trial running somewhere in the country or in the world into which this patient may be able to fit. So this is what I tried to tell you, that the incidence of EGFR mutations is very high in Asians as opposed to Caucasians. So this is the Chinese with 38.4%, the Japanese with 36.6%, Koreans with 32.4%. We fall between the Koreans and the Americans. About 30% of our patients will have EGFR mutations. The Americas are 24.4% and Europe has 14.1% mutation only. So it looks like the Europeans are not the ideal people have people to have this type of mutations. Well, so this is a chart which depicts the incidence of the mutation as given by the size of the circle, or the size of the mutation is, the incidence of the mutation is indicated by the size of the circle, and whatever is the target, which is whatever is the drug which is available for the target. So these are, of course, the targets for EGFR. This is for KRAS. So we have sotorasib for KRAS now, and then many others for ALK, a few for BRAF, the dabrafenib plus trametinib, and capmatinib plus tepotinib for MET. And of course, we know that for HER2/neu, we have TDM1 and its congeners as available for that. ROS can also be targeted by two of the drugs which can be used for ALK, that is ceritinib plus crizotinib, ceritinib or crizotinib, as well as lorlatinib. So we can use that. And we can likewise target RET oncogene as well as anti-RK oncogenes using different molecules. And entrectinib can also be used for RAS mutation. So when we started, we just had one drug, ceritinib. Now we have 1, 2, 3, 4 drugs for ROS itself, half a dozen drugs for ALK, half a dozen drugs for EGFR mutation, and so on. So as we observe more and more of these and start clinically recognizing that they are present, more and more opportunities for treatment of these mutations will occur. Now I have just given you the selected oncogenic drivers and their treatment in non-small cell lung cancer. Just concentrate on the PFS and the OS here. So the PFS and the OS, for example, EGFR, you can go all the way to 1.5 years to roughly 2 years of overall survival. Gefitinib is a little less than 2 years survival. Afatinib about a little over 2 years survival, and so on and so forth. So some like osimertinib have crossed 3-year survivals as well, where the PFS is 18.9 months. So it's important to understand that there is a dramatic difference in not just the overall response rate, very good overall response rate. All of them have crossed 50% overall response rate. Unlike any chemotherapy drug, you have good enough progression-free survival and extraordinarily good overall survival as well. Now, we know that they are no longer under development. Don't worry about the title. But we know that the first, second, third generation tyrosine kinase inhibitors for EGFR have different mechanisms of action. And we know that they are active or non-active against wild type versus mutant type versus the common drug-resistant T790M or L858R mutations. So what we need to understand is that as the mutations occur and the type of mutation in the EGFR is equally important to understand, so that we know what drugs can be used for targeting. If one drug fails, we can use the other drug, or upfront, if you can use the same drug, you can prevent the emergence of the mutant clones within the human body. So this is what I said. So typically the EGFR and drug bind to each other. So there's a close fit, but when T790M mutation occurs, ATP binds, but the drug cannot bind to the any longer to the EGFR mutation. I had talked to you a little bit about what happens when you have additional downstream mutations. So you can have very many varieties of developing resistance to the first-line EGFR blockers, gefitinib or erlotinib. So one is through the 790M mutation. The second is called a bypass. So the cell no longer uses EGFR, c-MET or AXL. So instead, it automatically switches on the downstream pathways, RAS, PI3 kinase, JAK, MAP kinase, AKT and STAT3 pathways, which give it a survival advantage. Or you may suddenly have a phenotypic change. So a non-small cell type can suddenly get a epithelial to mesenchymal transition. So it can have a non-small cells mesenchymal type. So it no longer behaves like a non-small cell non-squamous carcinoma, or it can actually get converted into a small cell carcinoma. So the reason why I have projected this slide is to understand that a resistance to a TKI need not necessarily always be because of a T790M. So it can be because of a bypass, or it can be because of a phenotypic change. So it stands to reason that each time the patient is not showing a response or is progressing while on treatment, it is important to reobtain the tissue, at least by ctDNA, to reanalyze the tumor to find out what is happening, what type of bypass mechanism or what type of mutation or phenotypic change is occurring. So this is what I have listed here, the frequency of EGFR mutations. So the frequency of atypical EGFR mutations, typical EGFR mutations, and where is this mutation occurring? Is it in the extracellular domain? Is it in exon 18, 19, 20, 21, or beyond the R22? So we can have very many varieties of mutations which can occur, and each mutation actually drives a different way the tumor actually starts behaving within the body. So it's important to understand that there can be a change as under the pressure of the drug you are using for the tumor to mutate and then obtain a resistance and progress. So this is what we have said. So that is what happens in the exon 18. What happens in exon 19? What happens in exon 20? The classic is T790M mutation and the L858R mutation, etc. in exon 21. So what happens is the ability for it to bind to the ligand goes down here. Ligand binding is very poor. Ligand binding is good here. And then autophosphorylation starts occurring. So it bypasses the mechanism by which the drug acts. So you have an EGFR mutant non-small cell lung cancer, not eligible for combined modality treatment, which is stage 4, start with gefitinib or erlotinib or afatinib, and the disease progresses. So you can classify that into systemic progression or oligo progression. If it is oligo progression, try radiation therapy or surgery and consider continuing the EGFR TKI. If it is systemic progression, as I said, please rebiopsy or do a liquid or tissue biopsy, analyze what is the type of mutation, use osimertinib for T790M. If it is T790M negative, liquid and tissue in the tissue and not possible, start using a platinum-based chemotherapy for the patient. If it is T790M negative, and there are other targetable molecular molecular changes available, see if you can put the patient on a clinical trial. And if there is a small cell lung cancer transformation, once again, the patient goes on to a platinum plus etoposide chemotherapy. So this chart in summary tries to explain to you how and why you need to follow up the patient, not just for the progression of the disease, but for a molecular reanalysis for the tumor which is occurring. So I have just depicted here what happens to these mutations, not just outside, but within the intracellular domain as well. So many very different kinds of pathways can be activated. This is of course dimerization. Once it is dimerized, you can instead of allowing anything to come from outside, any growth factor to come from outside, you can have an auto-dimerization, and that auto-dimerization actually drives the pathway which I have depicted here, and each one of them gives either simultaneously or successively or one after the other, you can develop this type of pathway changes. So here is a depiction of what happens when you have a MET oncogene overexpression in the presence of an EGFR. EGFR overexpression renders the EGFR tyrosine kinases to be ineffective. So you need to co-test for MET and see what happened. Why is this patient no longer trying to have any response to your treatment? So it can also be, of course, an expression of HER3 overexpression. Instead of HER2-neu, you can have a HER2-3 overexpression as well. So you can have a wild-type EGFR, and then you have used a first or second line treatment. You know that the median progression survival is about 12 months. overall response rate is 70%. If you use the third generation EGFR, you have an additional 7 months of median progression-free survival. The overall response rate, of course, is 80%. And then once they progress, it can be a T790M mutation, especially in those that have not used osimertinib. And in those who have used osimertinib, you can have a meta-amplification or other types of molecular changes which can occur. If, of course, you have a T790M mutation, you can start using osimertinib here. So you add another median progression-free survival of 10 months. So 12 plus 10, that is 22 months of median progression-free survival. You once again get 60% overall response rate. Well, it's not going to stop here. We need to see whether there is a meta-amplification here. Yes, if there is a meta-amplification here, you need to go back and use a MET inhibitor or a MEK kinase inhibitor. So that way you can tailor the treatment once again to using a second line and a third line treatment also. So in a patient with a progressive disease, during treatment with TKI, you see, perform the molecular analysis on liquid biopsy, use a targetable resistant mutation analysis. If it is absent, rebiopsy the tissue. If it is feasible, do a molecular analysis for PD-L1 or an oncogenic driver, see whether it is there is a driver or not. If it's not feasible, evaluate the potential benefit of other therapy for marker unknown or best supportive care as well. If there is targetable resistance mutation present, treat with the standard of care based treatment on the presence of the oncogenic driver. Whatever is the oncogenic driver, which I have depicted in the previous slide, try to use the same problem. Now, a little bit about immunotherapy and why it can be used. This, as you know, is the tumor cell population. The tumor cell population leads to a dysfunction of the T cell. All of you are very much aware of it. So it prevents the binding of the PD-1 to the PD-L1 is the epitope on the tumor. PD-1 is the receptor on the T cell. CTLA4 is the receptor on the T cell, and the epitope on the tumor is CD80 or CD86. It always binds to the tumor to recognize that it is self through the MHC molecules or to the T cell receptor molecules. So what we need to do is we have to use either an anti-CTLA4, so to remove the energy, ANERGY, or anti-PD-L1 or anti-PD-1 to remove the energy to see that the T cell is reactivated to recognize the tumor and then destroy it in the body. Well, we know that there are PD-1 and pembrolizumab and nivolumab are PD-1 and target PD-1, and atezolizumab targets PD-L1. Once again, the median overall survival is not bad. If you compare it with nivolumab, it is about 3 months here against docetaxel in the Checkmate 57 trial. It is roughly about 3 months again in the squamous non-small cell lung cancer. So the importance, as I said, if you have a squamous cell carcinoma and there is no driver mutation other than the PD-L1 expression, so use a PD-L1. A target PD-1 expression, anti-PD-1 monoclonal antibody. So you can use for squamous carcinoma as well. Pembrolizumab, the keynote studies show treatment naive versus previously treated, or pembrolizumab plus platinum-based treatment. The median overall survival is once again about 10 to 12 months more than what we achieve with chemotherapy alone. So roughly that is what you get. Well, should we use only chemotherapy or only immunotherapy, or can we combine immunotherapy with chemotherapy? Yes, of course. We have n number of studies to show whether you can use it with a platinum doublet. So pembrolizumab plus platinum doublet versus platinum doublet, and of course against pemetrexate plus platinum versus placebo plus platinum doublet, pemetrexate plus platinum. So once again, you have an overall response rate of 55 versus 29%, and a 2-year median overall survival of 22 months versus 10.7 months. So it is possible that you can have a very good response. For example, if you use durvalumab plus cisplatinum in non-small cell lung cancer, we get an event-free survival of 73% at 1 year. That's not very much to talk about, but this is amazingly good if you think of the other way around, that your chemotherapy is probably not going to work beyond 9 months in majority of the patients. That is the vast number of patients. Can we use immunotherapy plus radiotherapy? Yes, but not much difference in the 2-year overall survival if you compare durvalumab plus chemoradiotherapy versus chemoradiotherapy alone. So roughly about 10% increase in the 2-year overall survival. If you use ipilimumab plus radiotherapy, the overall survival is very poor. So ipilimumab alone as a drug has no place at least in oncology. Okay, pembrolizumab plus radiotherapy versus pembrolizumab. Once again, radiotherapy demonstrates doubling or a little over doubling of the overall survival rate at 2 years, and so on and so on. So if you come down to immunotherapy plus anti-angiogenic therapy, for example, sintilimab plus anlotinib, you get an overall response rate of 72.7%, which is phenomenally good. So you can use immunotherapy with radiotherapy, you can use dual immunotherapy, you can use immunotherapy plus targeted therapy, that is a tyrosine kinase inhibitor, or you can use immunotherapy plus anti-angiogenic therapy as the treatments in any of these, in any of those without a targetable driver. So these are the efficacy of immunotherapy for lung cancer. I have given here what is the characteristic of the patient in which it was used, and what were the agents which were used, and in situations in were used. So they were used in metastatic, in first line, in second line, locally advanced extensive stage small cell lung cancer, and recurrent small cell lung cancer as well. So we can use immunotherapy including in small cell lung cancer also. Now, how do we choose what to choose? One method has been, although it is not the best surrogate for choosing immunotherapy, we are not there yet in choosing the best surrogate as PD-L1 expression. So it has moved from category 2A to category 1 since 2019. Using immunohistochemistry, PD-L1 has more than 1% of tumors in 60% of advanced non-small cell lung cancer will express some amount of PD-L1, and a high level is found in about 30% patients. So 60%, 40% patients do not show any expression of PD-L1. 60% show some expression. That means it could be 1 or it could be beyond 50%. But more than 50% is seen in about a quarter of the patients or 1/3 of the patients. The second one is what we call tumor mutation burden. Yes, tumor mutation burden is a biomarker for any tumor, not necessarily non-small cell lung cancer. For immunotherapy, that is also a good biomarker. Recently, we have seen that tumor infiltrating lymphocytes, we always knew that a tumor which is full of lymphocytic infiltration did best with treatment. This is the best case scenario is actually triple negative breast cancer, in which we know tumor infiltrating lymphocytes are the best indicator, not PD-L1, not tumor mutation burden, but TILs are the best biomarker for predicting a response. But we are not there yet to formally introduce them into the system for us to accept. But this year, possibly in ESMO, we will hear something about TILs, at least in breast cancer and colon cancer. We have other driver gene mutations. We know that you should not use an immunotherapy if you have a driver gene mutation. So the response is much, much lower as compared to a drug which is targeting the driver mutation itself. This we know from EGFR and ALK studies. PI3K mutations, EGFR mutation, STK mutation, they do not respond to immunotherapy, and so on and so forth. Other biomarkers which we know are microRNA, neoantigens, MSI, extracellular vesicles, gut metabolism, etc., etc. They're emerging as possible predictive biomarkers for future use. So be on the lookout for the last line, last category which I have written. So this is a summary sheet of what to do when you have a PDL with no tyrosine kinase inhibitor mutation, so no targetable mutation, but you have variable PDL1 expression. 1 to 49, you can use pembrolizumab monotherapy. If you have metastatic non-small cell lung cancer, so if the patient is chemotherapy intolerable or unacceptable. If it is more than 50, you can use pembrolizumab once again as monotherapy. So two situations where you can use pembrolizumab as monotherapy. You have no TKI-directed mutation, regardless of the PDL1 expression, we can use pembrolizumab with chemotherapy. That is a category 1 recommendation. Okay. Or if you have a metastatic squamous non-small cell lung cancer, non-squamous cell small cell lung cancer, regardless of PDL1 expression, you can use carboplatinum, paclitaxel, pembrolizumab as a category 1 indication. So if you have a metastatic small cell lung cancer, regardless of the PDL1 expression, you can use itolizumab or durvalumab plus etoposide plus platinum chemotherapy as a category 1 indication. It looks like, in fact, you can use immunotherapy in a vast majority of situations where there is no targetable mutation within the cancer. Well, these are, of course, the adverse events and the principles of management of immune-related adverse events. I won't dwell on it any longer. This is my concluding slide. So you have a panel A is how to balance the biomarker-driven therapy versus standard non-biomarker-driven therapy, weighing the evidence favoring molecular alteration-based therapy versus standard non-targeted therapy. Standard non-targeted, by standard non-targeted therapy, I mean chemotherapy. And so if you have a tyrosine kinase inhibitor, there is a tier 1 indication that you must use biomarker-driven therapy. If you have a biomarker-driven therapy, and then that is the chemotherapy or immunotherapy can be used, but EGFR TKI or ALK-driven TKI or ROS-driven TKI is the preferred treatment over chemotherapy or immunotherapy. If you have a biomarker-driven opportunity for a lung cancer, which is low in PDL1 or HER2/neu mutation, first line, there is very little evidence to show that first-line HER2/neu directed therapy is superior. So the better thing seems to be a standard non-biomarker-driven therapy. Well, panel C, lung cancer, adenocarcinoma, once again, low PDL1, HER2/neu mutation, third line. Now, you have finished your chemotherapy, and now the patient has relapsed. Now start using a HER2-directed therapy. Although this is tier 2B recommendation. So you now can use as a third line treatment. So you have used here, and then you have used used a second line here. You used a third line here. You can use a HER2/neu directed therapy. But the evidence is not is still equivocal. Is speculative targeted therapy as fourth line. Can we use what line to use? Well, it is speculative. So it is for you to choose what type of treatment you want to use, whether you want to use biomarker-driven therapy, that is a PDL1 directed therapy, or TKI, or you want to use chemotherapy, or a combination of many different types of treatments is up to you. So I'll leave you with this cartoon from Charlie Brown. So you are all out there to do good to all of you. And here she is asking Charlie Brown, I'm intrigued by this view you have on the purpose of life. You say you are put here on earth to make others happy. Of course, we are put here. We have been made oncologists to make patients comfortable, live a very happy and comfortable life. So see that they lead a happy and comfortable life. So that is our purpose. So that's what Charlie Brown says. So after a small pause, he once again is challenged, what are the others put here for? Well, the others are put here for us to serve them. Thank you all for